We will now ask Dr. Suresh to come in and talk about how he approaches a patient with coronary AV fistula. It's a very interesting topic and there are some difficulties involved, especially you're dealing with very small vessels, tortuous vessels. So it will be interesting to hear how Dr. Suresh does this whole thing. It's very challenging too.
Thanks, Dr. Nageswara Rao and Dr. Radhakrishnan. Thank you for giving me this opportunity. Coronary AV fistulas are not very common things. So when you do see them, you generally need to innovate with regard to what you are going to do. We could start by defining what a coronary artery fistula is. It's a communication between the coronary artery and a cardiac chamber or a major central blood vessel. The idea is there is no intervening capillary bed. Most of the earlier series showed that more than half the major fistulae arose from the RCA, but more recent series where the smaller fistulae were also taken into account, the left side tends to predominate. But undoubtedly, the larger fistulae have a habit of coming from RCA, but also from the sinuses. 90% of the fistulae seem to drain to the right heart. They could present quite often without any symptoms, but the real large fistulae in the infant could be a cause for heart failure. And in adults with large fistulae, one or more of symptoms like angina, ischemia, infarct, heart failure, arrhythmias, even rupture, endocarditis, any of these things could occur. So fistulas are troublesome things. We use words like small, medium and large. It's interesting that Dr. Ladson applied some definite criteria to calling what is small, what is medium. According to him, if the coronary artery size is compared with the fistula, and the fistula is not more than twice the size of the normal coronary artery, you could call it a small fistula, and there is no proximal dilatation of the coronary artery in this. And if it is twice or thrice the size of the normal coronary artery size, along with the proximal dilatation, you could call it medium, and more than this, you could call it large. Such arbitrary criteria are required because an absolute size will not be helpful. You need to relate it to the body surface. A 3 millimeter fistula in a small baby is a large fistula. And QPQS is not really helpful because these are not huge shunts. And therefore, in deciding which fistulas to close, we need to factor in several things. Consider the age, the size of the baby, the symptom, anatomy. Is the child or the adult undergoing any concomitant procedure? Obviously, small fistulas do not require closure. But if they are medium or large, the way we defined, at some point you need to close them, and a child is old enough at 3 to 5 years to consider closure of them even in the absence of symptoms, because they are going to get into trouble. And there is also no doubt that a symptomatic fistula should be closed at any age. And things like a large shunt, ischemia, congestive heart failure or LV dysfunction truly force your hands. Evaluating a coronary artery fistula, you would definitely require a coronary angiogram, not necessarily by an invasive procedure to begin with. We would consider a CT angiogram very useful, not only to show the anatomy and to confirm the diagnosis. In practical terms, when you need to plan what you are going to do, a CT angio actually tells you that this helps you in making the decision that this is the device or the type of closure that you would employ. And you also need to consider, is this a candidate for surgery as against catheter closure? I'll dwell on this point later too, but generally speaking, too small a child, too small for the hardwares that we are likely to use, an extremely tortuous, non-navigable fistula, multiple drainage sites, or there is an uncomfortably close major branch which you don't seem to be able to exclude, or if you can't reach distal enough into the fistula. These are some of the reasons why we may decide not to do a catheter closure and straight away recommend surgery. And hardware that you choose, you generally take coronary catheters, particularly the guide catheters which will go more deeper into the coronary artery. and you need the guideways like the hydrophilic wires and floppy coronary wires, you would quite often require a snare. I would come into that. And the material that you are going to use could be coils, all types of coils, or it could be any type of device, particularly a PDA device or a vascular plug. And you would start by angiographically demonstrating the coronary fistula. You would like to balloon occlude the fistula at the point of closure and demonstrate that this is tolerated. You could cross antegrately in this context meaning from the coronary end, cross with a wire, bring it out, snare it out, exteriorize it at the venous end, and thus establish an arteriovenous loop which gives you the freedom to go with a venous sheath, with like a ductus delivery sheath or whatever the sheath that you want to use, into the venous end of the fistula and deploy what you want to do from there. You could also advance the delivery catheter, particularly a small tracker-like catheter, to the most distal portion coaxially through a guide catheter and deliver coils or microcoils. And in adults in particular, in context, a covered stent might come in handy in some cases. This procedure is not without complications. You could have the device or the coil migrating. There are instances where my friends have had and the literature have reported where the coil has retracted even into the left main, causing death. So you could have extreme complications too. And but these are readily imaginable complications. Some of the things that we are not certain about, when you are closing a fistula and you are leaving behind a normal coronary artery which is hugely dilated, what happens to the rest of the normal coronary artery system? The thrombus which is likely to form there is a potential hazard for ischemic symptoms. And in a study from Cleveland, Dr. Larson demonstrated that if you have a large fistula and a large coronary artery at a distal end, a fistula, then that the dilatation of that coronary artery in an adult is unlikely to regress and could be a case for later incidence of ischemic events. I would demonstrate some of the cases that we have had and go through their peculiarities. Look at this 11-year-old girl who had a continuous murmur on both sides of the sternum, and there was a right sinus to RA fistula. You can see that. And we decided to do this with an arteriovenous loop. Here is the wire in the pulmonary artery. That wire is being snared and brought down. Now an arteriovenous loop has been created. This now allows you to put a ductus delivery sheath into that fistula. You can doing a fistula angiogram, and then you have a ductus device at the distal end of the fistula. You're doing a coronary injection from the other end and demonstrating that it is in place. In this case, the 4-year-old girl with failure to thrive, again proximal right sinus to RA fistula. Here, see that, pretty large in a small child. Again, the arteriovenous loop is created, and here the balloon, you can see the balloon catheter. Balloon occlusion is being done to demonstrate that there is no ischemia, and an Amplacer vascular plug 2 is being deployed. You know, this 3-tier structure of the AVP2 is particularly useful in some of the large fistulae. That has been deployed, and the coronary end injection shows that it is nicely in position. So that has been released. In this case, here is a 40-year-old lady who had SVT. She was on antihypertensive medication, and she had a distal circumflex to RA fistula. You can see that when the left coronary injection is done, you have a normal LAD but a hugely dilated circumflex. She has had a ductus, one of the slides got missed, but what we have done is to use a ductus device like the first case to close the distal end of the fistula. This leaves behind this dilated left circumflex and several questions. The fate of the proximal dilated coronary is uncertain. We said that this leaves behind a risk of thrombus formation. She was placed on dual antiplatelet therapy. The benefit that she obtained was that her SVT disappeared. And 2 years after the procedure, she was clinically well. Her TMT was negative and she hadn't got into any problem. But she needs to be on lifelong follow-up and is at a lifelong risk of a thrombotic occlusion. Here is a 5-year-old boy with failure to thrive and with a continuous murmur at the lower left sternal border, echo showing RCA to RV inflow fistula. Here we put a pacing catheter in because a lot of tricuspid valve stretching would occur during the procedure. You can see that while the arteriovenous loop was created, the delivery sheath is stretching the tricuspid valve. This patient had all sorts of trouble during the procedure, dropping pressure, AV block. We had a pacemaker lead in initially, but it was all right. Eventually we got through and we deployed this. Because of the proximity to the caudal mechanism, this patient had a TE put in so that we were certain that we were not entrapping any chordae. So this was the final result. Unlike adults, the dilated coronary artery in children have a better chance of resolving with passage of time. In the next case, 7-year-old girl, there is a left sinus to RA fistula. If you see this, the injection is near into the left sinus. You see the huge fistula which is going and behind the aorta and opening into the RA. We had quite a few of these, and with a ductus device, the same technique as we described later, it has been closed. And in this case, a 23-year-old woman, again with left aortic sinus to RA fistula. I chose this picture to illustrate the usefulness of a CT angiogram in demonstrating the details of the fistula. You can see the fistula nicely and see that it is coursing behind the aorta and opening into the RA. That's the fistula. The 3D reconstruction is even more revealing. And this is the way we close the arteriovenous loop. You have the delivery sheath in, and that is the ductus device closing it. In the next case, a 15-year-old girl, again a left sinus to RA fistula, same technique. Of all these, this case was particularly interesting and particularly challenging. 71-year-old lady who was first diagnosed to have coronary artery fistula 4 years before the procedure. She refused any intervention until she went into atrial fibrillation, had congestive heart failure. So when she took her up, she really had pulmonary edema, on ventilator, hypertensive atrial fibrillation patient. Here again we had a CT angio. Look at the long tortuous fistula which is opening into the RA. We measured that RA entry point as 16 to 17 millimeters and decided to put a 20 by 18 cocoon device. This is the angiogram, and what is sitting there is a 20 by 18 cocoon device. She had a dramatic improvement. Now 2 or 3 years after the procedure, she continues to be in atrial fibrillation, but she made a trip to Vaishno Devi. Having said this, there would be also cases where we would say right away that no, we don't want to do this with a catheter. Look at this. I'll just come to the angiogram. This is a large tortuous fistula with multiple tortuosities and entering into the RA. They are very difficult to navigate, and some of them are better closed from both the aortic end and the RA end by the surgeon, as was done in this case. Or in this case of a 10-year-old child, a very mischievous fistula. Look at it, is a very small start. It expands into a huge aneurysmal sac before it opens into the RA, making the navigation through this very difficult. This patient also went surgical closure from both the sides, the aortic end as well as the RA end. And some of these were not using the picture. 3-month-old baby, severe cardiac failure, large fistula. The patient directly went for surgical closure. Or a 5-year-old child with a very short left main to LV fistula, whatever you put in there is going to protrude into the left main and you will stay clear of that. So this patient went to surgery through a limited left thoracotomy and patient did very well off pump. And these two slides I owe to Dr. Bharat Dalvi. These are instances which he uses to say which fistulas you can say directly, we don't want to deal with this. This is one instance. This is obviously small, normal coronaries, but with small fistulae leading from both the branches of the left. But here, in the next one, in a 72-year-old patient, you look at this fistula coming off the left main, they are pretty large. But again, whatever you want to do, you want to manipulate through the left main. And with the normal coronaries, why would you want to interfere with the left coronary in that? So, asymptomatic, hemodynamically well compensated, no evidence of chamber enlargement or technically challenging, some of these fistulae we are best left behind. Thank you.
Thank you very much, Dr. Suresh Kumar. I think it's a very good illustrative presentation. Yeah, we'll take some questions. Before that, I would like to ask you, what are the antiplatelet protocol in all these patients? And did you come across any late ischemic events in these children?
No, but I would say we have been fortunate not to come across this. In none of these cases did we have any ischemic event, but that's not due to the merit of anticoagulation. I believe it's a random chance. If you do large numbers of this, it is bound to come. Answering the first part of the question, in smaller children, let's say in the 5-year-old, 6-year-old child, generally we would keep them on aspirin. In adults, particularly say if it's a 40 or 50-year-old patient with a hugely dilated proximal coronary artery, where you have a question as to whether you should leave it or not, if you are doing that, we would definitely keep it on dual antiplatelet drug. Wherever you have a little greater concern about the proximal coronary artery and the size of the thrombotic segment that you are leaving with, we would use dual antiplatelets.
So you mentioned that the proximal coronary arteries usually not shrink in size following enclosure. Is it true even surgical ligation also?
Yes. Look at it this way. You have a 50-year-old patient. You have a huge circumflex or distal LAD. From that the fistula is going. This coronary artery has been several times the size of the normal coronary artery for 50 years. In the remaining 20 or 30 years of his or her life, this coronary artery is very unlikely to regress. Quite unlike this, there is data that in children with similarly dilated coronary arteries, there is definitely some reduction in size and near normalization, at least in some cases. So perhaps it is, or most likely, it is related to the number of decades of dilatation that it has gone through.
But there is data, sir, that surgical ligation also has the same similar.
In fact, if you look at the data which I presented, I had to rush through that for lack of time. The Cleveland Clinic data, the 16 cases, 4 surgical, 12 medical. All the complications were in surgical cases. But then, to be fair, one should say that they were the larger fistulae, they were the ones which were left behind longer thrombotic segments, they were the ones which never resolved. And the patient who had, in fact, 41 years later, there was one case like that, and who died. That patient had a grossly dilated circumflex which never regressed. So whether it is surgical or catheter intervention which is closing doesn't seem to matter. The degree of dilatation and the time duration in terms of years and decades through which it has been dilated, that is what matters.
The question is whether balloon inflation and fistulogram should be done or not.
As far as possible you should do it. The only instances where we have avoided it, say when you clearly have a sinus to RA fistula, you are clearly away from the coronary arteries, but even there you are demonstrating an angiogram within the fistula that by mistake, you have not confused it a proximal coronary artery to fistula for a sinus this thing, and there is a branch that coming off. So it is always useful to balloon occlude and see.
That's absolutely needed actually. Yeah. Right.
Yeah. See what the surgeon tries to do, the surgeon has one advantage that way. what is our concern when we are leaving behind a long thrombotic segment? This thrombosis spreading proximally. So some of the large fistula, the surgeons like to close from the aortic end like an RSOV and also obliterate the venous end. There's one case which I didn't show, which I had sent for surgery, with 3 huge aneurysms with a lot of tortuosity in between,
Yes.
which I had taken for cath closure, and then found that we couldn't navigate. In any case, it was too complicated a one. That when the surgeon looked at also, he found that there were more than one exits which we had missed because the huge aneurysm was covering the exit point. So the surgeon closed from both ends. And in fact, we did a TE initially after closing what he thought was the exit point, and we found that there was still drainage. We closed the aortic end, put some ligatures in between also, and then the whole thing was eliminated. So when possible, particularly with large fistulae, closing the aortic end if you are going in for surgery is a good idea.
No, but that does it not cause sometimes ischemia? If,
Why?
if it is supplied?
No, we are not speaking of ligating a coronary artery. No. See, when you have a proximal coronary artery to a chamber fistula, even if you are doing a catheter closure, like when possible, we would like to go close to that entry point so that most of the fistula is eliminated. The surgeon has the advantage in that he can watch. Surgeons also, when they are ligating, they are watching the ECG changes. So if there is an ECG change, the surgeon is going to back out. But these cases were particularly arising from a sinus, it is easy to close from the aorta. I am not speaking of closing of the aortic end of the coronary, no.
So in coronary AV fistula, you need to have different strategy for individual case, custom-made hardware. Like each case is different, and you don't know, sometimes you may end up backing out the case because of the tortuous course of the vessels. I think you have very much highlighted everything. It's a really very good information. I thank and congratulate all the 3 speakers for giving wonderful talks this evening. Thank you very much, sir.
Thank you.